Good morning. Thanks for coming. If you're looking for Sono games, you're in the wrong room. I'm Steve Bernstein. I'm at Yale. These are my colleagues, Patrick Carter and Will Meurer. And we want to talk to you today about some pretty neat advances in clinical trials designs that the three of us are using in various funded projects in the emergency department, and show you a bit about how we think these designs can be used in emergency medicine, and maybe we can have an interactive conversation as the talk goes on to hear some of your ideas about ways to advance this work. And just in terms of eponym introduction, so MOST is the multi-phase optimization strategy, and SMART is sequential multiple assignment randomized trials. And we'll talk about those, and depending how time works out, maybe we'll do a little more. Our work is collectively supported by these federal agencies, and they're really quite interested in working with these methods today. So the goals of our talk this morning, we have a good bit of material, is to go over classical clinical trial design, which I'm sure won't be new to you folks, but to show you what some of the shortcomings might be in those kinds of classical designs, and where MOST and SMART might offer some advantages. To give you some examples, of course, from the work that we're doing now, to distinguish these and discuss a little bit the terminology, which can get confusing, what's an adaptive design, Bayesian designs, et cetera, and maybe to talk about opportunities for future work using MOST and SMART designs in emergency medicine. So the sort of classical schema for a randomized trial, which has really been around now a good 70 years since Bradford Hill, has to do with, I don't know what is there a laser on this? This bar thing? That's the one that... It's the middle? Okay. Not a big deal. It's very, very light. The thing in the middle?
There it is. It's not showing.
Okay. Yeah, it's there. See it. It's not essential, but all right. So in a classical randomized trial, again, you have a source of patients who come in to your system who get recruited in some way. They have a baseline state or initial state. Of course, you get informed consent and determine what your eligibility criteria are. You pre-specify inclusion and exclusion criteria. If you're doing a randomized trial, and we're talking about randomized trials today, randomization so that every patient has pretty much an equal probability of winding up in any of the trial arms. In a classic two-arm randomized trial, I'll focus on that now just for simplicity. One of your arms will be a control receiving presumably standard of care, whatever that might be. And then you have an intervention arm that receives the study treatment. And of course, the only difference, what randomization gives you, hopefully the only difference between the two arms is this particular study treatment, whatever it is. You have to hold all other maneuvers, all accompanying maneuvers in check so that everybody else gets exactly the same thing, presumably. And randomization should make sure that all of your baseline covariates are roughly comparable between your treatment groups, right? Age, sex, gender, et cetera, insurance status, whatever it might be, should roughly be comparable. And of course, the larger your sample size, the better you are to have a balanced randomization. And then you measure your outcome of interest, whatever that might be. There are opportunities for bias at every one of these steps. And these are the techniques that we use to take care of them. So again, performance bias means that the intervention and the control or placebo, if it's a placebo, should be delivered the same way. And ideally, you would have a blinding so that the interventionist would not know what treatment he or she is delivering. The recipient, the subject, the patient, the participant, whatever term you prefer, doesn't know what treatment he or she is receiving. Not always possible, certainly in the studies we're talking about, which we'll talk about. And then ideally, in triple blinding, whoever's doing the detection, whoever's doing your outcome assessment, your research staff, whoever that is also blinded as to what intervention the participant receives. So triple blinded studies. That's sort of the classical design. We'll have some familiarity with that. There are some challenges with this other than, they're hard to do in a general way, but there are some specific methodologic concerns and issues in classical clinical trial design, which led in part to the development of the designs we're going to talk about. So the first one is this, and this affects my work directly. Many of the interventions we deliver are not one thing. one drug, you're comparing a new drug, some investigational agent versus placebo, or a new kind of imaging technique versus standard imaging technique. You've got one intervention, and that's fine. If you're working in behavioral health, like I work in addiction, mostly tobacco control, a lot of the stuff that I do is multi-component. So I might give somebody a motivational interview and some nicotine replacement medicines and refer them to the quit line. I'll show you all that in a sec. I do a number of things. I do 3 or 4 things at the same time. I deliver a package of interventions. If it works, that's great. But if it does work, I actually don't know what were the most efficacious components of my intervention. Did I need to deliver them as a package, or was it really, component A that worked, or component B, or maybe it was the interaction of components B and C? I don't know that. I'm not going to be able to know that. So that's one of the shortcomings in the classical design, is you can't disaggregate the effects of multi-component interventions. Another challenge or issue is cost is generally not considered when you design a classical clinical trial. You may choose to do a cost-effectiveness analysis at the end of it to look at the cost per whatever, per unit of improved outcome, cost per quality-adjusted life year, cost per quality. You can do that, but you don't pre-specify what kind of cost you're willing to consider, right? Which in part is why new drugs are so darn expensive. We don't really pay attention to cost at the time we design the trial. In the most design, cost is an explicit part of your planning of the trial. I'll show you how that works. And a third challenge in classical trial design is that it takes all this time, often years, to do the trial, to get to your outcome stage and do your outcome assessment. And again, if you have an effect, that's great. And if you don't, back to the drawing board. But if you don't see an effect, then you're kind of stuck. There's not much left to offer to these subjects. Like, where do you go next? Can you do something else for the people who you couldn't bring into treatment or who didn't respond to the initial therapy, et cetera, and still keep them in your clinical trial? Still do something else? Can you explicitly design a protocol that allows you to do more stuff if plan A doesn't work? And the smart design lets you do that, and my colleagues will talk about that too. So those are some of the concerns and challenges with classical trial design. Does that make sense to folks? We'll save some time for questions also. So the 2 people who've really done the most work in this area, who really developed these techniques, are Linda Collins and Susan Murphy. And I want to acknowledge them straight, right from the beginning. Linda is at Penn State. Susan is at Michigan. We've had the pleasure of working with and learning from both of them. Linda's a co-investigator on my R01. Linda designed the multiphase optimization strategy most, and Susan developed smart designs, and both continue to work in this methodologic space. They jointly run this really cool center called the Methodology Center, and there's the URL. If you're interested in learning more about these designs, that's a great place to start. Lots of links to their publications and so forth. Collins has a new book out on optimization techniques in clinical trial design. Okay, so the MOST design, as it's called, was actually not developed for healthcare at all. It was developed for in the world of industry, industrial engineering. So when you're trying to make a widget, make a thing, you want that process to be as efficient as possible, right? You don't want to waste time. For companies, always time is always money, right? So you want to do things quickly, analyze them, improve your process, and move on, but you keep doing that in an iterative fashion. You're never actually done, okay? So you have to manage your resources strategically. You need to be as efficient as possible, and business understands this in a way that medicine is just learning really still to this day. And that's called the resource management principle in the MOST design. And the other key component or key undergirding principle of MOST is just that it's optimization. So you're not trying to find the best way to treat something, because best implies that there's a potential end state. You're just trying to optimize. And if you think of it in terms of optimizing, the implication is that you're never necessarily there. There's always some asymptotic limit that you try to approach, but there's always another round of work you can do, another study, another trial to try to improve the efficiency and the efficacy of your intervention. Most designs, also in terms of efficiency, typically employ factorial designs. We'll talk about that in a moment. This is a schematic that comes right off of the Collins website from the Methodology Center that sort of outlines what I just said to you. So the idea is that this is an iterative cyclical process of optimization, evaluation, which in our context actually means a clinical trial, seeing if it worked, taking the optimized components and then testing them again, maybe adding other things, other subcomponents if you think that makes sense, evaluating them again. And once you think you have an optimized intervention, because at some point you have to call it a day and move on, right? Then you can kind of push that out into your company, your clinic, your hospital, your whatever. Okay. So that's the general approach to this strategy. So this is how I used it. I published a clinical trial 2015. Now, I'm sorry I forgot to add the reference. This was in Annals of EM in 2015. I did a clinical trial of a multi-component intervention in our ED at Yale to treat adult tobacco smokers. We enrolled 788 people, and the control arm received the typical kind of smoking cessation brochure. The intervention arm got about 4 things. They got the brochure. They got 6 weeks of nicotine patches and gum. We physically gave them the gum, not a prescription. And we started the first dose right in the ED. We put the first patch on them right then and there. No, we put on their lavalier. We started it right in the ED. We gave them a sort of a condensed version of a motivational interview. We called it a brief negotiation interview, a BNI. And we actively referred them to the state smokers quit line. Every state has a toll-free quit line you can call. So we gave them this package of stuff. And then we followed them up to 1 year out. We called them at 1 month, 3 months, and 12 months to see how they were doing. The primary efficacy endpoint was at 3 months. And we called them on the phone, and we said, "Are you smoking?" And if the answer was yes, we thanked them, and that was that. But if the answer was no, we had them come back to the ED, and we had them blow into a tube to measure their exhaled carbon monoxide, which is a standard tool to do biometric testing of smoking status. And at 3 months, the intervention arm had an abstinence rate of that versus about 5% in control. So this is a strongly positive study with an effect size of 7%. Number needed to treat of 14 if you want to think that way. So really, pretty cool result. And so this was published in Annals. So, we were happy about that. That was kind of neat. Actually, the first trial to show that you can do abstinence from ED for smokers. But, of these things that we did, which actually gave us the most bang for the buck? What was the most efficacious? We have a cost effectiveness paper in review right now, but what about the cost contributions of each of these? And were there any interactions, between these? We don't know that. I cannot disaggregate that. It cannot be done statistically and methodologically. So I thought about this and, learned about most and called up Linda Collins, and she said, yeah, that's cool. And it turns out she was already working with another tobacco group in Wisconsin. So we thought, well, let's do a most trial. Let's see what we can do to try to disaggregate the effects of these things. And that's what we're doing right now, actually. And I'll just sort of walk you through how this works. So from that first trial, we kept the counseling interview, the motivational interview. We kept the nicotine patches and gum. We kept that warm referral to the quit line. They get the brochure, but that's less interesting. And we added a texting program. There's a smartphone program run by the National Cancer Institute, NCI Telsmoke. It's a freebie. And so we added that as another arm. So now what we're doing is we're testing the effect of each of these in an on-off condition. So every patient can get this or not, this or not, this or not, this or not. So we have 2 to the 4th arms in this study. So this is a 16-arm clinical trial. So the green means the person gets the intervention, and the red means the person does not get that intervention. So these are it's pretty straightforward, combinatorics, right? So these are the 16 potential arms. So 1/16 of the sample gets all 4 interventions, and the 16th gets nothing. I mean, you get a brochure, but everybody gets that. And so this now allows us to look at the effects of individual interventions, but we can also study the effects of combinations. We can actually look at interactions also. And we're powered to look at two-way interactions. I don't think three-way. We're powered to look at two-way interactions. So you can do that also in a factorial design. Now, This is what's called a full factorial design, insofar as every possible combination is an arm in our study. You don't actually have to do that. You may choose to specify a priori that you're not interested in looking at texting alone or some combination. You know, if you think there's some clinical reason that that's not an interesting combination, then you can do a fractional factorial design. You can eliminate, you know, one of these rows or two of those rows, or that's up to you. That's sort of a clinical methodologic decision. That's not a statistical decision. It actually doesn't change the power of your study by much. It really doesn't. Okay. And this is a more efficient way of studying the efficacy of these rather than doing, let's say, a series of head-to-head trials, you know, counseling versus meds versus quitline, et cetera. So that's part of the efficiency that you get from most designs. Does that make sense? We pre-specified an effect size of a delta of 5%. So we want, for any one of these, we want to see an improvement of at least 5% in the quit rate, absolute percentage points, to say that this was an effective intervention. In this trial, we said it was 7%, right? But that was doing like the kitchen sink. So in this one, I wanted a narrower effect size, because you may only get, you know, one or two of these things. So we said 5%. Obviously, that inflates your sample size a little bit. We pre-specified the cost constraint. And again, this you would not do in a typical clinical trial. So remember, in optimization, you decide not only what worked clinically, but also what worked economically, what worked in terms of cost. So to retain a component in your next trial, it has to be clinically efficacious, but it also has to fit within your cost constraint. So we pre-specified that for us to retain any one of these interventions in a subsequent trial, it could cost no more than $5,000 per quality. Okay? And that number didn't come out of a hat. Actually, tobacco treatment in general is very cheap. It's about $1,200 a quality. It's like one of the most cost-effective things you can do in clinical medicine. The others are aspirin and vaccinations, actually. So we just floated it up a little bit, $5,000 per quality. So if an intervention would be clinically effective, but would cost more than that, we wouldn't keep it. We'd throw it out. We're not going to retain it. You have to do both. Okay? That's most. And that's what distinguishes most, by the way, from other kinds of factorial designs. And so I do a bit of grant reviewing, you know, for NHLBI and some other institutes. And a lot of people are starting to label any factorial design as a most design. I think in part because this has a certain sort of curb appeal at this point. And Collins and I talk about that, and it's not the case. For our trial, we actually added one more evaluative arm, which is novel, not part of traditional most. So this is what I just told you. We have the intervention component. If it is clinically efficacious, we retain it in the final package. If it's not, it's out. And then we see if it's cost effective, like I just said, and if it's cost effective, we retain it. But I said to Linda, well, that's cool, but you don't really talk to the patients to see what they like, what worked for them, what was feasible, what was a hassle. What about doing that? And she said, yeah, I guess we can do that. That's okay. So we are doing some semi-structured interviews, some qualitative work with subjects at the end of the study, a subsample of them, probably about, I think almost about 10% of the sample from all arms. And we're going to talk to them about feasibility, acceptability, et cetera. And again, for each of these components, right, for each of these components. And so if they tell us that it seems to hit these marks, then we'll retain it as well. So we have 3 evaluative arms in this study. Clinical efficacy, and these are just the analytic modalities that we're using for them, okay? So each of those components, to be retained in the next study, has to be clinically efficacious, right? It has to work. Let's start with that. It has to hit the cost constraint of no more than $5,000 per quality, using sort of standard econometric techniques. And it has to be feasible and acceptable to patients using standard qualitative approaches as well, all 3. So we're evaluating across 3 domains in our MOST trial. The study is ongoing. Our projected N is just over 1,000. We have about 600 people recruited so far. We anticipate completion of recruitment around April of 2019 next year. And so far, the group quit rate overall, it's still blinded, is about 10% biochemically verified quit rate. So we'll see what happens once we break the blind, after we're done. And we do the qual work as we move along as well. So we're about halfway through the qual work too. Yeah. So that's most. Kit.
So how does that affect your sample size calculations? Because in the ideal world, you'd love to do all those arms, but it seems like it's a drain on power.
Yeah.
Sorry.
I heard him. So the question is about power and sample size. So it turns out it really doesn't have much of an impact at all as you add arms. What it is more specified by traditional measures of beta and alpha, and our delta. Our delta is 0.05%, right? You inflate it a little bit because you're looking at some interactions as well. We're looking at two-way and three-way interactions. I didn't get into all of that. But it's still pretty efficient. It's still pretty close to a two-arm clinical trial. That's the cool thing about most.
The arms aren't considered independent because they're not.
Right.
So parameter estimates can be informed by people from multiple arms.
And I'm going to switch gears a little bit here and talk
Let's switch mics.
Okay. Is that working? Okay. So I'm going to switch gears a little bit and talk about SMART trials and give an example of one we're doing in the ED. So I think to start with, it's helpful to differentiate between what a SMART trial is and what an adaptive intervention is. So an adaptive intervention is basically a sequence of individually tailored decision rules that specify whether, how, when, and based on what measures to alter the dosage or type of treatment that somebody's receiving, and this is determined at critical decision points during the course of their care delivery. So an example is kind of the simple example here. This is an intervention for weight loss, and your initial step is to enroll patients in the treatment and get 5 sessions of individualized behavioral therapy for weight loss, and then at some point make a determination about whether they're responding to that or not responding to that. And you can pre-specify a goal of, let's say, 5 pounds of weight loss, and if they lose more than 5 pounds, then they're a responder and you can continue the treatment, or if they don't, then they're a non-responder and you can choose to augment that with another type of therapy like meal replacement therapy. So at its most basic, sort of simple step, this is the concept of an adaptive intervention that changes over time. We do this in the emergency department for conditions like migraines, where we have our initial sort of treatment option, and then we move to our second stage if the patient's not responding, and so on. So the components of adaptive interventions are to have a series of treatment options and then tailoring variables, which you decide how to adapt the treatment course based on their response or non-response, and then a decision rule that basically governs how you are deciding what the individual treatment options are. The reason why to use these types of interventions in clinical practice are mainly around chronic health disorders, things like obesity, substance use, depression, violence, where the person may need an adapted course of treatment over time. There isn't a single intervention. They may have multiple relapses or recurrence of disease. There may be external individual or environmental factors that influence their disease course. And there's a high degree of heterogeneity in their response to treatment, both within the person over time, as well as between different participants or people. So where the SMART trial comes in is in determining what the best type of adaptive treatment strategy is. So as opposed to the standard question is, does the intervention work or not work, that we would test in an RCT, what we're testing in a SMART trial is what are the best series of tailoring variables or decision rules to design an adaptive intervention that then we can test in a fully randomized control trial. So the end goal is different than your standard RCT. Some of the design principles around SMARTs are that the critical decision point has a binary responder status. So did they respond? Did they not respond to the initial stage treatment? And then that should be based on a relevant clinical metric. And each, this is sort of intuitive, but each treatment option that you select should have some strong scientific base for use. the power for the study is based on the main effects aim, and that's what allows you to have all these individual groups, as I'll show you in a minute here, but you don't have to have this enormous sample size in order to examine your aims. And then the advantage of the SMART is that you can embed scientific questions within that to look at how to more deeply tailor your adaptive intervention design. So the sort of common SMART scientific aims across studies, so there's usually one or two main effect aims, which is looking at the efficacy of essentially the first stage or the second stage treatment option. Within the second type of scientific aim, which is more of an embedded aim, you focus on how the first and second stage treatment strategies may work synergistically or antagonistically to impact the outcome. So it's essentially an interaction examination. And then the third aim, which is often a secondary aim, is an optimization aim, where you can look at tailoring variables that you didn't consider in the original SMART trial design, but that may be relevant for the design of the adaptive intervention. So I think it's helpful to look at an example, and this gets a little bit complicated, but so going back to our weight loss example, and this comes directly from Susan Collins' book on this topic, but so you enroll patients in a, I don't know if you can see this, but you enroll patients in a trial where they initially get 5 sessions of therapy for weight loss, and maybe randomize you to get assessed at that point or to get 5 sessions. If they get assessed at that point, then they're either a responder or non-responder. Oh, sorry, that one's not working. They're either a responder or non-responder. If they respond, then they continue their therapy that they're getting currently. If they're a non-responder, then they get re-randomized to either augment their current therapy with meal replacement therapy or to switch to a different type of therapy altogether. And that gives you 3 specific groups here. In the group that got randomized to get more sessions, they get an additional 5 sessions. So they get a total of 10 initially up front, and then you assess their response at the end of their 10 sessions. And they either continue if they're a responder, or they get re-randomized to get the meal replacement, or they switch to a different therapy method, again leaving you with 3 groups. So in the main effect aim, what you're looking at is either the effect of the first stage treatment, so 5 sessions versus 10 sessions, where you're comparing groups A, B, and C pooled together, and D, E, and F pooled together, or you're looking at the second stage treatment option here, where you're among non-responders looking at whether it's better to augment with the meal replacement therapy or to switch to a different type of therapy. So you're comparing groups B and E together, pooled together, and C and F pooled together. In the embedded aim, what you're looking at is comparing 2 types that, well, you can do a number of different comparisons, but you compare 2 types of adaptive intervention strategies. So, for example, is getting the 10-session therapy followed by getting the switch to a different therapy for non-responders better or worse than if you did 5-session therapy followed by the meal replacement augmentation. So there you're comparing groups A and B versus D and F. Or you can compare all 4 different treatment strategies that are there. So here again, you're pooling again A and B, A and C, D and E, and D and F. So A and B to look at this treatment strategy versus A and C, where you're looking at switching to the different therapy, D and E, where you're giving the 10 sessions up front, or D and F. And the third one, which doesn't appear on the screen, is the optimization aim. So here, what you're doing is you're looking at additional tailoring variables which weren't included initially up front in this design. So maybe you want to assess whether or not people who are binge eaters should go for the initial 5 sessions or 10 sessions. So you might stratify your analysis looking at whether baseline binge eating, similar to a moderator analysis, has a different outcome whether you start with the first stage strategy of 5 sessions or 10 sessions. So I'm by no means a statistician, but I thought I would hit a couple of points about data analysis considerations. So for the main effects, again, you're pooling, and it's similar to any other type of longitudinal study and longitudinal analysis that you would do. For the embedded aims, you have to consider whether or not you need to do a weighted or a replication approach to your regression analysis, because if your design, one of the groups is getting randomized and one group is not, then you're going to have underrepresented groups within the final data that you're looking at. So you have to wait for that in your analysis. Similarly, if you're pooling groups and comparing 2 groups where A is part of both the groups that you're comparing. You have to replicate the data in order to account for the fact that the A participants are in the larger group. In the optimization aim, it's similar to a standard moderation analysis, and you use a type of analysis called Q-learning regression analysis. So the example I'm going to talk about is from work that we're doing up in Flint, Michigan with the Safer Teens study. So the original Safer Teens study is a brief intervention for alcohol and violence. The study population is 14 to 18-year-olds who came into the emergency department and had a history of past 3-month alcohol use or aggression. They received a 30-minute counseling session delivered by a therapist that incorporated motivational interviewing and cognitive behavioral skills training. The initial study reduced peer violence out to 12 months and reduced alcohol consequences in 6 months with number needed to treat of 8 and 17. And we replicated that within a universal sample. But given the initial modest effect sizes, we went back and took a look at who responded and who didn't respond at the initial 3-month time point and found that those with higher levels of delinquency were the ones most likely to not respond, indicating that maybe we needed a more intensive intervention for that group. And I should just acknowledge that the original PIs of the study were Maureen Walton and Rebecca Cunningham. So the next piloting of the next stage of what we wanted to do with this was to look at whether or not augmenting the initial intervention for folks would have an effect. So we ran 2 pilots, one that looked at adding a post-ED text messaging system to their initial brief intervention. So they get the brief intervention, they get texting for the next 3 months post their ED course that delivers tailored text messages on a daily basis. And the other pilot that we ran was giving them the brief intervention and giving them also 8 sessions post-ED of more intensive remote delivered therapy for the patient population. So the SMART trial that came out of this is the question of which of these packages of interventions is the best way to design an adaptive intervention. So the first 2 aims are the main effect aims, so looking at what's the best first stage strategy, either starting with brief intervention plus text messaging or brief intervention plus what we were calling health coach, that remote therapy portion, to reduce alcohol misuse and violent behaviors. And aim 2 of the study is to look at the best second stage strategy, which I'll show you in a minute here, for those who respond and don't respond at the 4-week time period. And the secondary aims build on those other in the embedded aim of the SMART trials, as well as the looking at baseline and time varying moderators of the adaptive strategy effectiveness. So the overall kind of design for the study is we screen folks in the emergency department. If they screen positive for recent violence and alcohol use, they get randomized in either the group that gets the first stage strategy of brief intervention plus text messaging, or the first stage strategy of brief intervention plus the health coach and remote therapy. At week 4, they get assessed for response in both arms, so based on binge drinking and violence behaviors. And if they're a responder, they get randomized to either stay the course and receive continued text messaging or step down to a group that just gets a pamphlet or brochure. If they're a non-responder, they get randomized again to either stay the course with the text messaging or stepped up to the more intensive health coach option, where they get remote therapy post-ED. In the arm that starts with the first stage strategy of brief intervention plus the health coach, they again get assessed at week 4. And if they're a responder, they either stay the course with the current health coach therapy and finish out their 8 sessions, or they step down to a control group. If they're a non-responder, then they either stay the course with the health coach, or they step up to what's called Health Coach Plus, where they get both the remote therapy sessions as well as a lot of intermediate contact with the therapist in between sessions. And we're assessing outcomes again at 4 and 8 months. So we've just started to enroll this month with a study, and kind of see where it goes next. And with that, I'll turn it over to Will.
All right, thanks. I'll try to be brief so we get some time for questions, which is a little challenging for me, but whatever. Thanks all of you who pay taxes. I get some money from the government there. All right, so I think just to put a little bit of review here, when we talk about the word adaptive, some people may know me as a fan of adaptive clinical trials, and that's a little different from what we've been talking about before. And I'm just going to throw this out here just to get a sense as to, so you can hopefully simply phenotype things. when we say a between subject change based on some algorithm, like we're going to be testing 3 doses, and if one of those doses is looking better, more patients are going to get assigned to that. That's an adaptive clinical trial. The randomization ratio for different arms can change for different reasons. Even very strictly speaking, a interim analysis that does a blinded sample size re-estimation or an interim analysis that has a futility or an efficacy rule, those could be considered adaptive clinical trials, although we wouldn't consider them as strongly adaptive. Then, if you think about a study that's doing within subject changes based on an algorithm, these could be adaptive interventions, as Patrick noted, dynamic treatment regimes, micro-randomization, potentially SMART, because something is going on along an algorithm. Now, both of these are using individual subject response to inform trial conduct in some way, but these are very different. Now, that may make you think, could you do both at the same time? The simple answer is yes, but not anyone is really doing this that at least I'm aware of. The analytical methods would become extremely complicated. Many adaptive trials use Bayesian models, and they're sometimes fitting models that are more complicated that you can't write an equation to solve. And then most of the work in SMARTs and most in DTRs has used more general closed-form frequentist statistical models. It's not to say these people can't talk to each other. This is the Reverend Thomas Bayes. And it could be done. It just hasn't been done yet. So anyway. Here are a couple of my examples. My main background is as a stroke researcher, so I'm going to present a simulation study of a SMART I did in collaboration with Kelly Kidwell, who works with Susan Murphy at Michigan, and then a real trial that uses a MOST framework called Reach Out in a 2x2x2 factorial way. The thing about being a stroke researcher is we use this horrible outcome measure called the modified Rankin scale. It's this ordinal non-interval thing, and it's just so annoying, and most of the time we dichotomize it, we do a sliding dichotomy, and there's just so little information in each event, and you have to wait 3 months, and so I moved on to doing something with blood pressure, because it's like this really cool continuous outcome, normally distributed. It's like there's more I can learn from this, so that's why I branched out into hypertension, and reducing somebody's blood pressure 2 to 4 millimeters of mercury has a real impact in reducing hard cardiovascular events. So as a surrogate outcome measure, blood pressure is actually one of the sort of most well-studied and sort of true. So in the problem with stroke and why, a little bit of this simulation study is sort of a message to the stroke community like, hey, you're doing clinical trials wrong. Good luck. So we are often making clinical care decisions based on changing patient status with uncertain future outcome. But clinical trials, at least as classically done in the drug space or the device space, are typically addressing a single decision at a single time point, which is not how real life works. So if we think about stroke, let's say we want to look at let's say we want to replace TPA. I've often said that I think that the chances that TPA is the best molecule to treat stroke are basically 0, right? Somebody could design a better molecule. We just haven't done it yet. It's a matter of will, money, et cetera. So if you wanted to do a study, though, now that we've moved to find large vessel occlusions, pull clots out, and so forth, there's 2 big questions, right? Can we replace TPA? And can we replace these cath labs with some second drug? It'd be easier to give a second drug after TPA doesn't open the artery, maybe, or some other drug. And how are you going to figure out if that's going to work? And then what are you going to be missing? And one of the things, in terms of this simulation study, we go into a bunch of different things to kind of pick out what should be the regimen. If you respond to lytic A, that's great. You don't need a second stage treatment. But people who don't respond to lytic A, and whether that's NIH stroke scale at 2 hours or whatnot, you have to have some definition of that non-response. Do they go to the cath lab, or maybe do they get this new medicine? Easier to give, faster, could be given in more places. We don't have to have specialized treatments. And sometimes you can't even get the clot out, even though you try, and you fly somebody across the country to get it done. Then if you also want to compare this new lytic, what if more people respond? That's good. But what if amongst the non-responders, more people would respond to this new medicine? That's, in the current way that we do clinical trials in stroke, this is like unknowable, because you would do this trial, lytic A and lytic B would look the same, and you would say, well, let's not go on to lytic B. We've been using lytic A, Multiphase, since I was in high school, and I'm not that young. And it's just, it's 90s, 80s tech from a 90s trial, and like we really can't do better now. But anyway, so to look at this from this perspective, when you do this, one thing that's very frequent for us is you simulate under some various assumptions, what is the likelihood that you're going to get to that answer from your given trial design? And in this, we set this set of assumptions in that lytic A and lytic B, you have a good chance of response to both of them, very high chance of response. But if there is no response, then in the cath lab, if you get the new medicine, it works better. If you got lytic, it works better than the cath lab. The new medicine is effective at the second stage. But then if you had gotten lytic B, it's a lot better at the second stage, even though at the first stage A and B look the same. So this is this idea of there's something that we could discover that we won't because of the way we design clinical trials. And in this, when you simulate this design, you have to look to make sure, gosh, is my design giving me a bunch of false positive results? And here you can look at the probability of success. In a null case, you simulate that nothing happens, the treatment effects are the same in all of these different arms or potential areas. And here, how often is it finding that this new medicine is better? And you can see that, while close, the confidence intervals overlap here a little bit, but it's estimating the truth well, there's separation from these things. If you finish this trial, you don't have a definitive answer that you should start using that new lytic, but you do have a lot of evidence to do a larger trial where you could definitively prove that new strategy, if you go back to this, that this, even though this A equals B, that this strategy is advantageous down here across the bottom. You're going to make the most people, or you're going to try to prove this in a final trial where you kind of go down, use this approach, you're going to prove that that could be the most effective approach. And by randomizing at the second step to prove that this new medicine is better when you start using lytic B. So that's one example. There's a lot of other examples that we went through, but talking through all the different scenarios would be a challenge in this forum. And again, this is sort of the power in terms of if the study was, in terms of finding that there was some difference across these regimes, it has quite a bit of power if you can spend 1,500 patients, even at 700 patients, still, in 240 along each of these, put into these pathways, about 83% power. So still a pretty good design to get a sense as to whether one of these regimens should be tested further. So, it's an omnibus test. So again, we wouldn't discover this in any current stroke trials. All right. So the problem with hypertension, moving on to the next study, is we measure a ton of blood pressures in the emergency department nationwide, and we mostly do not act on this data. And maybe we shouldn't act on this data, but it seems a shame that we collect it all and we mostly ignore it. Like somebody has uncontrolled hypertension, they have an ankle sprain, we prescribe them ibuprofen, something happens in their kidneys, their blood pressure goes up even more, their ankle sprain doesn't feel better, we should have just given them an ice pack, but whatever. So Reach Out is using the multiphase optimization strategy to try to come up with a new ED-based intervention for blood pressure. And in our preparation phase, we did some pilot work where we looked at a self-monitoring intervention where people got texted healthy behavior text messages. And this was done by Leslie Scaleras up at Churches in Flint. And then I pitched an idea to our local stroke group where I wanted to just give everybody in the emergency department hydrochlorothiazide. All the other people in our stroke group said that was crazy, and Leslie had this great idea that we would start handing out blood pressure cuffs instead and doing the texting. And we did that in a sort of pilot study just to see if people would actually text us back and still be hypertensive. So that study, we were successful in getting people to text us back, and a pretty high proportion were still hypertensive. So we submitted a grant to the National Institute of Minority Health and Health Disparities and got funded for a design that uses the most framework. And in this, the idea is the healthy behavior texting, like the, keep up the good work, eat less salt, etc., is that going to be helpful? And this is a 2 by 2 by 2 factorial, like similar to what Steve was showing before, although his was 2 by 2 by 2 by 2. Every other day self-monitoring versus weekly self-monitoring, active provider appointment and transportation, getting people rides to their appointments versus go see your, messages that say go see your doctor, and then look at what happens with their blood pressures over time, with the primary outcome being the systolic blood pressure. And we could talk about diastolic blood pressure is important too, and that's fine, but we don't really have time for that. And then from this, the goal is to choose the components that basically we would need to make some trade-offs, and we haven't been as overt in terms of putting a quality threshold on this as Steve was. But if my expectation is, let's say, somebody who gets all of these things, we reduce their blood pressure 5 millimeters of mercury, but somebody who gets almost nothing, it goes down 4. Then maybe that's just sending them a weekly text, what's your blood pressure? Maybe that's adequate, and because that incremental addition of only another millimeter of mercury for all the work we have to do to get these people appointments and everything like that, that might not be worth it. And again, the idea is to sort of estimate what is the contribution of blood pressure reduction of each of these components. And we would look at interaction terms as well. But again, when you think about this, it's not that, and these are some of the types of messages, in terms of dealing with decreasing salt intake and so forth. When you go through all these, and again, this is sort of another way of looking at this, we do have this sort of screening phase where we text people for a few weeks to make sure they're actually really hypertensive, and then they get randomized at that point into one of these interventions, this sort of enrichment phase. Because some people maybe don't want to text you, maybe they just want $20 and a blood pressure cuff, and that's great, they can take that. But then we're going to focus the resources on the people who are responsive. We're going to try to keep balance between males and females, older and younger adults, and whether or not they've been on blood pressure medicines recently, by doing stratification in each of these groups. And then, yeah, they can get into one of these 8 different arms, which again look similar to, it keeps going too, similar to Steve's slide where you see like each of the 8 different ways to do the 2x2x2 combination. We don't have, as he had, like anything that would be a completely, what we consider like a complete nothing or control group. But in this, our lowest, people in primary care have shown that blood pressure self-monitoring at home is associated with a reduction in blood pressure. But since we need to text people to have them give us blood pressures, so we have measurements over time in people, we felt that this would be reasonable as the sort of lowest level intervention. And if this reduces people's blood pressure alone by a substantial amount and adding all these other things doesn't work, that still is a very helpful finding, because I think that gives us a guide. In any sort of learn phase trial, the big goal at the end is to know what you need to do next, whether it's a new study or whether it's change practice. And this isn't designed to change practice, it's designed to pick one of these 8 strategies. Or we may learn from qualitative or other data that we need a different strategy, or we need to add something into this or subtract something off. In terms of the final analysis, again, this is something that I was sort of mentioning before. You don't have 8 independent arms. You're basically coming up with parameter estimates as how much blood pressure can I expect to reduce from each of these individual components with indicator variables here, with the intercept being that sort of lowest level of intervention, or this kind of group 1, so to speak, the expected change in blood pressure there. So, and we have a statistical analysis plan where we would evaluate interaction terms and secondary analyses. And you could conceive of, at the end of our study, having a table where we look at what is the estimated overall reduction in blood pressure versus observed for each of these different groups. I'd like to acknowledge my collaborators on this. Leslie Scleris is a stroke neurologist at the University of Michigan and a close friend. Mackenzie Dome, our project manager, with whom we could not do anything. Kelly Kidwell, the statistician. Nick Seawald, who worked on the simulation study. And that simulation study has all the R code, so you could replicate that. Obviously, the institutes. And I think with that, we are going to open everything up to questions. We got stunned silence.
So great work, guys. So Will, I'm really interested in this kind of, these pragmatic type of designs. And so it's interesting to me that your study is just looking at a particular group of minorities. Can you talk a little bit more about that? And I'll frame this in my own work that looks at genomics, right? And so you sort of get a little bit more of this homogenization. And so some of that pragmatic aspects around what medications, actually you may sort of be changing that a little bit. And so I would like to hear a little bit about the implications of the choice of your group in a pragmatic trial, number one, and number two, a little bit more on the detail around and of course I can go to clinical trials and look more at it, but just interested in the drugs that are actually being employed as well and how you deal with those.
Yeah, those are both very good questions. So I think, Pat or Aaron, I think the the racial distribution at Hurley's emergency department, it's not exclusively African American. It's about 60%. So it is a bi-ethnic population. In a sort of deindustrialized city in the Midwest that's had some external troubles. So it is at the Minority Health and Disparities Institute. As an aside, we got sort of interesting feedback from a different NIH institute, which I will not name, that thought we should do the study exclusively in people who are African American, which we didn't choose to do. So it's a community-based study. It is a community that has a large proportion of African Americans, but it's certainly not all. So in terms of genomics and those things, we will be collecting information about race, ethnicity, and kind of it would be a potential parameter in our sort of final models, but we're not doing stratification to make sure there's absolutely strong balance, as we are for, in contrast, for gender, we do think there are very potentially big differences in how men and women might respond to the types of intervention we do, so we do want to maintain balance within each of our groups on that. In terms of drug regimens, we are agnostic to that. Again, everybody talked me out of my give everybody hydrochlorothiazide, although now I've been talked into it would be chlorthalidone. That's not what I give people from the emergency department, but whatever. Just from the perspective of some of the operational quirks of this. And interestingly, our goal is to get people back into primary care clinics. At least in Flint right now, the primary care doctors are primarily managing hypertension. At the University of Michigan, though, it's actually primarily clinical pharmacists, and that may be a model things moved to before. I've said before, I think maybe blood pressure medicine should be over the counter, et cetera, but that's not where they are now. So we are collecting information on what drugs people are on, but we are, as an exclusion criteria that was added at peer review at NIH, if somebody is like on a lot of medicines and uncontrolled, then they aren't eligible for our study because they need to be seeing nephrologists and so forth. But most people aren't maxed out on 3 medicines or 4 medicines. I forget exactly what our hard exclusion is, but those are all very good points. So we don't have current plans on the genomics end, but we're going to collect and see what medicines people are on, but we're agnostic to that. It's not part of our design.
I'll just comment on Flint in terms of, and I touched on this in a lecture earlier this year, which is there's an idea among social scientists that after the kind of influx of white people from the city of Flint, even though Flint is still like 55 to 60% black, the city is essentially racialized as a black city. So I would probably argue that a lot of what you're measuring ultimately is racism. And I'm always skeptical about race as a biological marker per se, but I think that essentially, I'm glad that you were encouraged to do it that way, to include everyone, because I think that everyone in Flint ultimately is kind of the victim now of systematic racism. So, and then I actually have a question, which is, I'm trying to learn a little bit more about the Q-learning methodologies. I know the work has kind of come out of ISR, so I wasn't sure as Michigan folks if that's something. I know, Will, you have a reputation for being a nerdy stats guy, so I don't know if that's like, if I understand it correctly, it's basically that you're doing like linear regression in multiple stages in the SMART trials. Is that kind of an apt way to describe it?
So I think at least in the one that we designed, we didn't. That wasn't the analytic model that we used. I think that's a possible model. I honestly don't know enough about it.
I'm really interested in these types of models, and I think it's awesome you guys present it in this forum because I'm interested in opioid use disorders and harm reduction, and there's so many elements to the harm reduction piece, and given where people kind of come in at their whatever their crisis brings them to the emergency department, I think these things are really like cool ways of approaching the fact that it's not really realistic to try to randomize people in these two groups. So I think it's awesome.
I noticed the first speaker incorporated the costs into the methodology. The subsequent speaker, I didn't think I heard the cost as a priori, as an element for your design.
It's not an a priori element to the design, but we've built in cost measures as part of what we're looking at.
The second question I have is, it seems to me, traditional trial is a lot of what you're doing potentially, the way I sort of thinking about it when you present it is sort of incorporating a lot of phase 2 studies pretty much, sort of in sequence to a certain extent, right? You're trying to do it, like you said in the last one, trying to find a optimal strategy then potentially you want to test that in a more robust, traditional randomized control trial. Is that sort of the sense of some of these methodology is sort of trying to, traditionally the basic scientists will be doing one-to-one comparisons, and then you kind of trying to add them all up in sort of the bucket, I guess, in the basket, and try to find that in an efficient and effective way. Is that fair to say?
You want to briefly answer that, because I think we have to conclude.
Yeah, we should probably wrap up after this. Thanks everybody for coming. So, none of this is really phase 2 in the FDA sense. We're not really looking at investigational agents or therapies or diagnostics, right? So we're really looking to optimize combinations of treatments that are most efficacious, that are within a fixed cost constraint, or to define treatment algorithms that seem to most efficiently get people to whatever desired outcome we want from them. That's how I think, that's right. Does that sound about right? Yeah, that's how I think of these things.
Yeah, and I look at it as, is it a practice-changing study, or is it a study that will lead to the practice-changing study? And I think that's what we're into. All right, thank you.
Thanks, folks.